We'll next hear from Scott Sirota, who is the president and CEO of the Blue Cross Blue Shield Association, which is the nation's largest health insurer, covering 1 out of every 3 Americans, 100 million Americans. He has been with Blue Cross Blue Shield Association for over 2 decades, or nearly 2 decades, and as CEO since 2000. And in addition to his work as CEO, he has served a number of civic leadership positions. He was appointed by President George W. Bush to the Policy Committee of the White House Conference on Aging, and has served in other roles, including, I noted, on the board of directors of the Chicago PBS station. So thank you for that as well.
Good morning. I want to welcome you personally to what I believe will be an extremely valuable educational session for you today. The agenda is terrific. Started out with a bang, as it were, and I think that you have a great lineup of experts. As you have done so far, I would encourage you to engage these experts, ask them questions, add your own perspectives to the dialogue. Because dialogue is what's critical here as we try to move forward and really, truly transform the healthcare system. As I'm sure you're aware, the timing couldn't be better. The marketplaces opened yesterday, or on the 1st rather, a key milestone for the Affordable Care Act. Our Blue Cross Blue Shield plans, my colleagues across the country, have committed in virtually every state to provide the communities that we serve secure and stable coverage that Blue Cross Blue Shield stands for. We will continue to work as hard as we can to educate consumers about the new choices that they have, to make sure that they can find the coverage that they want and that they can afford. More importantly, we will continue to partner with healthcare providers and other stakeholders, including those of you in this room, to find solutions to make sure the healthcare system delivers safe, high-quality, and affordable healthcare to all Americans. That's truly the transformation that's necessary. We have to ensure our healthcare system provides that which people expect. This afternoon, you're going to hear from Dan Hilferty. Dan's the president and CEO of Independence Blue Cross. He'll share some of the really innovative work that he and his team have done in their marketplace to improve quality and affordability. They cover the counties around Philadelphia. The kinds of things that you hear Dan talking about are examples of the hundreds of initiatives that are going on by Blue Cross Blue Shield companies throughout the country, all meeting with some degree of success, and are continuing to evolve as we move forward due to input from people such as yourselves. We're leading the market in developing and executing value-based programs. These programs, which we have in place in 49 states, including Puerto Rico and here in the district, focus on switching payment away from volume and toward value. We've engaged with more than 150,000 primary care providers in accountable care organizations, patient-centered medical homes, pay-for-performance, and episode-based payment programs. More than 23 million Blue members across the country have access to these kinds of programs, and these programs work. They're improving care while helping to control costs. Every day we're adding to these programs, learning more about what works in the local markets, because that's where care is delivered, and building on our successes with our provider partners. We believe that's the future of healthcare: partnership and collaboration at the local level between payers and providers to find solutions that work for all Americans. Thank you for your participation today, and I encourage you to make the most of the program that we have today. Again, thank you.
Thank you, Scott, and thank you to Blue Cross for their support of today's event, which makes it all possible. Our next panel is what it means for patients and providers. The Affordable Care Act will expand health insurance through a combination of measures, including expanding Medicaid eligibility, tax credits for employers, new rules for insurance companies, and requiring individuals to buy health insurance and more. This conversation is going to look at those changes from the perspective of all stakeholders, examining costs, benefits, and the effect the changes have on the healthcare system. Our panel is moderated by Marilyn Werber-Serafini, who is the Communications Director and the Health Policy Advisor for the Alliance on Health Reform. She previously was the Robin Toner Distinguished Fellow and the Senior Correspondent at Kaiser Health News, and was also an award-winning healthcare and welfare correspondent for the National Journal magazine from 1995 to 2010. Joining Marilyn on stage for this discussion are Kirsten Axelson, who is the Vice President for Worldwide Policy and Public Affairs at Pfizer, Dr. Jean Johnson, who is the Chair of the Board, as well as of the Nurse Practitioner Healthcare Foundation, and the Dean at the George Washington University School of Nursing. Jennifer Lee, Board Member at the Arlington Free Clinic, Alyssa Passament, the Executive Vice President of the American Society for Clinical Laboratory Science, Thomas Prysolak, the President and Chief Executive Officer of Cedars-Sinai Medical Center, and Dr. John Sefrin, the Chief Executive Officer of the American Cancer Society. Quick reminder, please do tweet all your thoughts, comments, and questions at hashtag NJCountdown. We have a great, robust dialogue going on. I'd like to keep that going. And with that, Marilyn, I'll turn it over to you.
Great, thank you. Good morning. So we have a lot going on. Millions of people are about to become insured in January. We saw the phones ringing off the hook yesterday and the day before at healthcare.gov. We saw the system actually go down. For the politics, regardless of Republican, Democrat, conservative, liberal, regardless of what people are believing, people are interested, people are going to sign up. There will be more insured people, either through the private insurance or through Medicaid. At the same time, many people will be left uninsured. So what will be the effect? We have a great panel with us today, and this is a pretty straightforward question, but with different answers for just about everyone on this panel. So we're going to start off with an insurance question. There are many insurance changes in this law. So John Sefrin with the American Cancer Society, can you give us a sense for how insurance is going to change? What are some of the differences in the rules in this law? We're talking about changes with pre-existing conditions. What does this mean for the country's sickest patients and for all patients? What does this mean?
Well, I think it's transformative. I think the choice of the word transformation for this conference is highly appropriate. And this is true for all patients, but particularly, I would suggest, cancer patients. It means that for the first time in the history of the Republic, people will have access to survivorship. My organization is the largest voluntary health organization in the world. We have 3 million volunteers and $1 billion in revenue. When we got started 100 years ago, there were virtually no cancer survivors. Today in America, 2 out of 3 cancer patients are survivors. The key point, the third loses his or her life most often because of lack to access to health care through insurance. So when the American Cancer Society started 25 years ago, the National Cancer Database with the American College of Surgeons, we have the only database in the country that could show during the debate on the Affordable Care Act the following. It has stage of diagnosis, outcome, and whether you have insurance or not. And so we were able to show the American public that a woman with stage 2 colon cancer with insurance had better 5-year survival rate than a woman with stage 1 colon cancer who got treated. Very important point. It's no surprise to anybody that if you don't have insurance, you're likely to present with a later stage disease. It's a total surprise to see that even if you get diagnosed at stage 1 where no one should die, you're more apt to die because you don't have insurance. So it would be difficult for me to exaggerate how important the Affordable Care Act is, because for the first time in history, all of our citizens will have access, in the case of cancer, access to survivorship.
So, John, for patients, for cancer patients, or really for any patients, what are the most important insurance changes in the law?
I think for cancer patients in particular, think about it for just a minute. My wife is a breast cancer survivor, couldn't get health insurance. Now, anybody who needs health insurance can get it. There are no annual or lifetime caps. If you have a serious cancer, children can sometimes exceed a lifetime cap in 1 year of treatment. And then I think what's really important to remind everybody, and that is, however we build this out, the centerpiece is going to be access to preventive services. And we now know that over half of all human cancer is preventable during a normal human lifespan. So if people now have access to colonoscopy at age 50 when they need it, or some other kind of test, we can actually prevent a colon cancer from occurring or prevent a colon cancer death from occurring. So this is huge and transformative for all patients, but especially cancer patients.
Okay, so we know that a lot of people will have access to coverage. What about access to care? With a lot of people entering the system, the question then becomes, will there be enough providers, especially primary care providers? And there is talk about a potential workforce shortage. Gene Johnson, do we have enough primary? Gene Johnson.
Yes.
Do we have enough?
Yes.
Do we have enough primary care providers? One, and in what areas? We're not just talking about physicians. A lot of states are now talking about scope of practice laws and changing scope of practice laws so that they can create new opportunities for advanced practice nurses. So one, tell us what the prognosis is for workforce issues, and then help us to understand what's going on in the states right now.
Well, I think that the workforce issues are certainly a challenge, and we don't have a quick fix in terms of having an adequate primary care workforce. But there have been, the Affordable Care Act has included, funding to expand the primary care workforce through traineeships and, loan repayment programs. These have been fairly successful. There have been, I think, about 1,600 nurses now supported through the National Health Service Corps, because there has been, significant funding added to the National Health Service Corps, to get people into the very underserved areas. However, even with those kinds of capacity building efforts and efforts on the financial incentive side in terms of a 10% bonus payment for 5 years to primary care practices, paying for fee-for-service and managed care Medicaid patients the Medicare rate, and some other financial kinds of things such as paying for care coordination, I think that there may be a greater viability, financial viability for primary care practices. However, even given the financial incentives and the workforce expansion efforts, we still have a problem with scope of practice for nurse practitioners. Nurse practitioners are a major workforce in primary care. There are 130,000 nurse practitioners currently, and that number will continue to grow. There can be more nurse practitioners produced, at a quicker pace than physicians. And I am certainly not saying that we don't need physicians, or that nurse practitioners will replace physicians, because I am a firm believer in interprofessional practice. But unless nurse practitioners can practice to the full scope of their education and clinical decision-making skills, that's going to limit the services that patients will be receiving. And right now, 17 states plus the District of Columbia have allow independent practice, but basically it's unsupervised practice. All of the rest of the states require some level of supervision, either specifically for prescriptions or for diagnosis, treatment, and prescribing. One of the things that we do know, the states where there are limitations, there is also a pretty great need, in terms of primary care. HRSA has recently, the Health Services and Resources Administration has recently noted that there are 57,000 geographic areas in the country that are primary care shortage areas. And that's significant. That is current. With the additional, folks through the ACA, the demand will become even greater. And just to address those needs, an estimated 15,000 additional primary care providers are needed, and we just really don't have the production capacity. And with the ACA, numbers up to 45,000 additional primary care providers being needed has been estimated, and we don't have that capacity.
So let me open this up to the rest of the panel. Who are patients going to be seeing when they get this new coverage and they want to come in and see? Are they going to necessarily be coming in and seeing a doctor? Who else are they going to be seeing, or where are they going to be getting their care?
I think you're going to find that people are going to seek out care wherever they can find it. And so you may find folks coming to the pharmacy, talking to the pharmacist about their illnesses. Pharmacists and pharmacies all over this country are doing some laboratory work on contract basis, and that gives patients access to some information that they currently don't have. Laboratories in this country are already trying to figure out how they can be better at giving patients access to not only the care that they need, but then the information. And in fact, CMS at HHS has proposed a change in HIPAA and CLIA regulations so that laboratories will be sharing patient results with the patient. And it will enable the laboratory community to fill some of that gap in primary care by also being available to explain and then refer or give the patient some information so that they can move on to the next caregiver. Because there's just not going to be enough time for what we can traditionally call the primary caregivers, physicians, nurse practitioners, and PAs to cover all of this landscape.
So are you saying that the folks at the lab are going to have new abilities to work with patients?
Well, they already had the abilities, they just never exercised them as well as they should have in the past because they always deferred to the primary care provider. But with the system the way we believe it's going to evolve, there's not going to be enough folks to go around. And so laboratorians of all levels are going to have to step out and help patients better than they have in the past.
How are the labs situated in terms of workforce? There are going to be so many new people in the system. Are there enough folks in the labs to handle the influx?
No, and that is the concern that we have, just as the nurses do and as primary care docs do. There's no way to know yet how many extra folks we will need. In our profession, we have the ability, because there are levels of entry, to be able to help with some of the gaps. But once you get to the level where you need scientists and PhDs and pathologists to talk to patients, then that shortage is going to be rate limiting, or has the potential to be.
Yeah, Marilyn, I'd like to jump in for just a moment about one of the things that I didn't say is that, we don't know exactly what the provider workforce is that we need if we re-engineer how we do things. And we don't do population care very well. We're still in primary care doing one-on-one care, and we're not looking at the systems, looking at the population, and really saying, how do we best deploy the variety of healthcare workers that we have? The clinical lab folks, physical therapists, pharmacists, everyone. And I think that is a really key thing. And I think that the Centers for Medicare and Medicaid Innovation really looking forward to seeing what kinds of things come out of that.
Go ahead.
Sorry. We expect a lot of newly covered patients will be seen at community health centers. Mm-hmm. Now, we as a free clinic, we don't get federal or state funding very little to
Right,
no
and explain to us what the difference is really between a free clinic and a community health center.
Sure. So the community health centers, federally qualified health centers, and health centers similar to them get federal funding, and they've gotten support through the Affordable Care Act in particular. So a lot of them will are expecting to see these newly insured patients. Our clinic, like many other free clinics, get little to no state and federal funding. So we're really supported by private donations and corporate donations. And they're really a product of communities trying to fill a gap to provide care to those who don't have access. And we think we very much will still be needed during and beyond the implementation of the ACA, because there will be millions of patients who still won't have access to care, or maybe they'll have coverage, but they won't have care, as you mentioned.
I agree with the observations that I think in the early going especially, people are going to go where to the places they're familiar with. And so I think in the early going, even people with additional coverage now will go to the community clinics, the free clinics. They'll continue to going to hospital emergency departments. Now, hospitals are actively working to try to redirect patients in that regard with coverage and get them into a traditional primary care kind of setting. But whatever point of entry, your opening question about, I think, the adequacy of the provider network is a very real and legitimate concern. I think Massachusetts' experience with that has indicated that, and I agree with Jean's observation. Oftentimes, this question gets posed, well, should it be nurse practitioners or should it be primary care physicians? The reality is, in order to accommodate patients today, even in a redesigned system, we're going to need more of both, of those kind of practitioners. From a physician standpoint, there's a real problem in that regard because there are restrictions on the number of residency positions that are available. And so this past year, for example, graduates of American medical schools weren't able to get a residency position. And there are limitations on the Medicare program now and the available training slots that Medicare is willing to pay for. So that issue has to, I think, be examined as well.
So from the health system perspective, is this something that you are able to, what do you do about this? What is your role in trying to oversee this?
Well, the major medical education and research centers around the country, including my own Cedars-Sinai, today actively support a number of training programs above what's paid for through the federal government, as well as offering advanced nurse practitioner training and advanced pharmacy training, for example, in order to facilitate the growth of new providers into the system. So those positions, frankly, are being paid for through the commercial insurance side of things, as well as the philanthropy that comes into institutions like ours in order to support those kind of training programs.
So that's a medium-term, longer-term approach that should be able to help down the road. What do you do starting January 1st? As you mentioned, this was a problem in Massachusetts, where we saw long waiting lists for people to get in to see physicians. So how do you deal with this? If you have people who can't get in to see a physician, they show up at emergency rooms, they show up at your clinics, they show up at, you have new working relationships with the hospitals and the physicians and your clinics, your systems. Right. What are you doing to prepare for the short term?
Well, the passage of the Affordable Care Act, I think, really turbocharged a lot of work that was already underway to provide more integrated and coordinated care throughout the healthcare system. The point Jean was raising earlier, but I think about breaking down the silos that have existed traditionally. And so what's happened, I think, throughout the country is you see a lot of different kind of partnerships that are developing, partnerships between hospitals as well as between hospitals and physicians. Those are small P partnerships and capital P partnerships, both kind of forms. And I think how it plays out in every community is different, responding to the particular dynamics and needs of that local community. I think that's one thing to keep in mind as health reform is rolling out. As mentioned earlier, Medicaid expansion is an example of something in which this is a federal law, but it's not really being implemented uniformly throughout the country. And so that's just one example, I think. How the exchanges are rolling out around the country is very different as well.
And Jean, back to you for a minute. How close are we with some of these state scope of practice laws, or some of them I believe are already passed and in place, that when patients go into a physician's office, that we may start to, they may, instead of seeing their doctor, that they may be seeing a nurse practitioner, or when they go in to see the pharmacist, they may, the pharmacist may be doing more. I mean, are we going to see a system starting next year where the patients may be getting more than they, instead of relying as much on the doctor, that we may actually see a different system where we are seeing more providers? Where are we actually in the process?
Well, we're already well on that way, because there was just a recent study done by some really good colleagues, Bob Phillips, who is a family physician, and 10 years ago, around 2000, only about 30% of family physician practices practiced with a nurse practitioner or PA. They repeated that study, and 50%, actually a little over 50% of practices now in a family physician's practice with an NP or PA. And that's a big change. Plus we're seeing in the healthcare landscape the emergence of retail clinics, which are largely staffed by nurse practitioners. And there has been a big investment, in terms of, establishing those clinics for convenience and for very specific, kinds of problems. But, I can tell you, I sort of wondered when they first emerged, okay, so how successful will they be? My adult kids, take their kids there when there are ear infections, when there are minor things, and, they're being used. And, certainly, as I understand, with expansion plans by the corporations that are supporting these clinics.
Okay, so we've talked mostly about lots of people getting insurance, but there are going to be many people who do not get insurance, either because their Medicaid has not expanded in their state, or because people choose to pay the penalty and not purchase insurance, or the cost is such that they will not be required to pay the penalty, so they will not get insurance. So we will be left with some level of uninsurance in each and every state. What happens to these people? Where are they going to get their care? How is it going to affect the various provider areas that we're talking about, the health system, the free clinic, how is it going to affect your cancer patients, some of whom may be left uninsured? How is it going to affect your individual areas? How is it going to affect providing pharmaceuticals for these folks who are left uninsured and still are not able to afford to provide them?
Sure.
Do you want to kick us off? Start us off about the pharmaceuticals?
Sure. From patients right now who are uninsured are either paying cash for medicines if they need them, going without, or getting assistance through a patient assistance program provided by pharmaceutical companies. Pfizer will continue to provide patient assistance for people who have difficulty meeting their medication needs, similar to the way Pfizer continued to provide patient assistance after Medicare Part D was passed. There were still seniors who had trouble getting access or affording their medicines.
Okay, so what's going to happen to the uninsured? Because we are still going to have some uninsured people.
I think those uninsured people will continue to go, again, they'll go where they've gone historically. They're going to go to the free clinics, they'll go to the community clinics, and they'll continue to come to hospital emergency departments. And in the case of hospitals, we're both obligated by law, but also by charter and by mission. America's emergency departments have been treating these patients for quite some time, and we're expecting that will continue going forward.
Right, so you're obligated through the EMTALA laws to basically stabilize them, but they're not going to get extensive treatment.
Yeah, they'll go they go through the stabilization process, and then we as hospitals have up until now, we'll be arranging for their continuation of that that ongoing care after they're stable and able to be transferred.
Can you please tell us how hospitals are going to be able to handle this financially? Because as part of the law, hospitals are losing some funding that they have traditionally gotten called DISH funding that is government funding that helped to make up some of the losses from uncompensated care.
Right.
So some of that money is lost because these people were going to be covered, and now some of these people are not going to be covered.
Right. Well, it goes back to what I was saying earlier, how the law is being implemented around the country differs. And so Medicaid expansion, for example, is a good example of that. When the law was originally passed, the concept was that there would be reductions over time in DISH funding for Medicaid and Medicare as new people were added into the system. And that was an approach that the American Hospital Association supported at the time, but that was under the concept that Medicaid was going to be expanded uniformly nationwide after the Supreme Court decision. That's different. And so from the American Hospital Association standpoint, one of the issues that we believe needs to be addressed is to come up with some way of titrating the DISH adjustments that's consistent with the new enrollment that's taking place. And again, how that's going to take place will differ state by state.
What is the chance of the federal government or the state governments stepping in to give back some of that money to the hospitals?
I gave up trying to predict congressional decision making a long time ago. And from the state standpoint, I think the states really don't have the kind of funding to be able to expand that in any significant way. The consequence is that the hospitals will continue to provide a significant amount of charity care as part of our mission.
Okay, Jennifer.
Yeah, Marilyn, back to your question about what happens to the uninsured. This is why we know that free clinics will still be very much needed in every community, and why we don't expect that our patient demand or workload will decrease at all. We'll need even more support because we've seen more need in recent years. And we know the situation is different in every state and every community. In Virginia, we're in Arlington, Virginia. Virginia has not yet decided to expand Medicaid. And so the majority of our patients actually don't have any new good options yet. We hope that they will in the future, but right now, those who are at 100% of poverty or above may have access to some subsidies through the marketplace, and we're excited about that. We want to get them connected to new options. But those who are under, the poorest, actually don't have any new supports right now without Medicaid expansion. So we're just as busy as ever. We need as much support as ever, and I would imagine most free clinics are in the same boat.
Are you concerned about continued support? Is there a perception that free clinics will no longer be necessary?
There is that perception out there that now with the Affordable Care Act and expanded coverage that free clinics won't be needed anymore, and that's just not true. There will always be gaps in care, whether, again, we know that there will be so many who continue to be uninsured. Again, those who decline coverage or who are not eligible still, and those who have coverage but not access to care. And so we are committed to meeting those gaps and continuing to provide care for the neediest patients no matter what the situation is.
Mm-hmm. And Elisa, your folks, how do you deal in the clinical labs with the uninsured population?
Well, in this country, the laboratory community is arranged somewhat, is not homogeneous. We have very, very large laboratories, what we call the big reference labs, LabCorp and Quest of the world. They already have built into their business plan the absorption of some uncompensated care, as do all of the hospital-based laboratories. We know in hospital-based laboratories that a number of our patients that we see we're never going to be reimbursed for what we do, and that in the past has extended itself to even people with insurance, as you mentioned earlier, because cancer patients tend to always overspend their caps, and we watch them in the laboratory. There are patients we We worry about them just as everyone else within the healthcare continuum does. And we know that there's going to come a time we'll be running laboratory tests on folks who won't be able to pay. That will continue, especially for the population that is not documented in this country, but will still need to access health care mostly on an emergency basis. In addition, there are a lot of small, what we call neighborhood laboratories. They already do a lot of Medicare, and they will also see the same level, if not an increased level, of uncompensated care as that care gets shifted away from the private laboratories.
Okay, so Kirsten, I wanted to get back to you because we haven't talked a whole lot about pharmaceuticals here, and yet there are effects when it comes to pharmaceuticals of this law. So walk us through what some of the effects are. What is the impact?
Sure. So, Pfizer, like all the innovative pharmaceutical companies, started to help pay for the coverage expansion starting in 2010 through new fees and discounts and rebates that were included in this law. All that notwithstanding, we believe this is the right thing for Pfizer's patients. Pfizer's in the business of bringing medicines that help enable longer, better lives at every stage of our life cycle. And that's difficult to do when you don't have the predictability that insurance brings. No one plans on getting cancer. No one plans on getting rheumatoid arthritis. So when you get it, insurance helps bring you through that very difficult time. We look at how innovation in medicines have turned cancer into a chronic disease. But in order to be able to stay on and maintain and have adherence with your cancer regimen, you need both the predictable access to insurance and also the reforms that are in place in the insurance market that means your insurance can't be taken away from you. So these are all important things. The coverage expansion this year through both Medicaid and the Health Insurance Exchange brings new people into the marketplace, but there are also new people getting new discounts. And so from sort of a revenue perspective, that doesn't offset the new fees to the industry, but again, it's the right place. The goals of the Affordable Care Act are not just coverage expansion, but they're also improving quality and reducing costs. And those are two places where pharmaceuticals are instrumental. Pharmaceuticals are effective in avoiding more expensive health types of interventions, such as hospitalizations. In fact, the Congressional Budget Office recognizes that and uses cost offsetting methodology when they consider the cost of medicines in Medicare. They actually are known to reduce other medical costs. And then quality is another area where pharmaceuticals used effectively can really improve outcomes. Prevention, one of the important parts of the law, pharmaceuticals are key to prevention. Part of prevention being effective is that you don't just get your screening, but you can also follow what your doctor asked you to do in your screening. And so we look at essential benefits. We look at some of the benefits designs that are coming out in the Health Insurance Exchange, and really hope that patients look carefully when they select a plan. Because if you go to your doctor and get your free visit for smoking counseling or obesity counseling or your free cancer screening, and medicines aren't covered on the formulary of your health benefit, that you're not going to be able to follow along with your doctor's advice.
Okay, so you're talking about how you all will be working with patients in new ways, and I'm wondering if some of the other folks on the panel can talk to us about new ways in which providers will be working with patients.
Well, just to follow up on what Kristen was saying, one of the things that we have been doing, pharmacy and pharmaceuticals and the laboratory have been working together for a while now, that as new drugs are released to the market, there are also companion diagnostic tests that are released that help to monitor the therapy so that you can either determine compliance, determine whether or not you're approaching toxic levels, or whether the patient's within therapeutic range. And this has helped to move diagnostics, not only diagnostics, but pharmaceuticals forward, because you now have people using drugs at the appropriate level at the appropriate time and not overutilizing or possibly experiencing downstream complications because they did not comply properly with what they were told to do as far as their drugs are concerned. And the laboratory is very key in helping physicians decide when that drug needs to be prescribed, when it shouldn't be. We also, in the laboratory, have started to develop a lot of molecular testing that helps to determine whether or not a patient will even respond to the therapy, which has helped pharmaceuticals direct their research. So all of this will in the end make us much more efficient than we were in the past. And I think that this will happen or continue to happen as long as we all are working together and looking at patient outcomes rather than looking at our own individual silos like we used to.
Along those lines, I think hospitals and physicians are working together between those two entities, and then those two entities working together with patients on this whole question of quality and efficiency. And so both in the hospital setting as well as in the physician office setting, hospitals and physicians are working together to first make sure things are developed on a professional basis based on the individual physician groups themselves, and what's the right care in the right place in the right location to make sure the patients are getting everything they need, but also avoiding things that don't make a difference. I think we all recognize that part of the problem in the American healthcare system has been things that haven't made a difference. And there's been very active dialogue going on in hospitals around the country with their medical staffs, hospitals and physicians working together in the ambulatory setting to identify those kind of things. And then, importantly, creating the systems and the ability, whether that's through the use of information technology, but also providing the physicians with the information they need to have the conversations with the patient based on their particular diagnosis and their issues. And those range from the management of chronic disease to what happens in the acute setting in the hospital, up to and including the very difficult things that physicians have to deal with in their offices when it comes to things like discussions around end-of-life care and issues related to hospital care around end of life. That whole panoply of issues, I think, have all kind of risen to the surface and are getting a level of attention that's just never occurred before. And I think if you look at some of the early indicators, I think we're seeing some of the results of that. Various things like hospital infection rates and things of that nature are dropping. I think the data with regard to the cost trend in healthcare in the last few years, I know there's a lot of debate about how much of that is structural in terms of real change and how much is that related to the recession. I can tell you that from what those who are practicing in the field, there's no doubt that some portion of that, some significant portion of that is a function of the kind of work that I was just describing.
Yeah, I think there's going to hopefully be a transformation between how healthcare providers really interact with patients. I think that may be, one of the biggest areas, and I think that we're only at the very beginning of understanding how to use social media, how to connect with, patients through electronic means and those kinds of things, and also working with groups of patients, rather than one-on-one. When you have a group of people with chronic illness and the same chronic illness, having group visits are proving to be, reasonably effective. So I think that how providers really work with patients is already changing. I mean, I think that many of us have experienced patients coming in and they've already explored websites and know a lot about, what may be going on with them. And they're basically looking for confirmation and some additional information. But they're also wanting to be really engaged in the decision making. And that is something that the ACA has recognized,
Yes.
In terms of the patient engagement. That is a very major issue. And so I think providers are going to need to know and learn how to better engage ourselves, with patients and not necessarily expect patients to be, engaging with us. It's going to be a very interesting transformation in terms of that relationship.
So how is that happening, John?
Well, I wanted to pick up on what Jean and Tom said by relaying the following. Right after President Obama signed the Affordable Care Act in the White House, he came over to the Interior Building to speak with the Vice President to an auditorium full of people that had been engaged in the Affordable Care Act. And the first words out of his mouth, we got to get this right. And the point I'd like to make here at this juncture is this incredible, historic opportunity we have to build out a healthcare system that really works. It's so difficult, and we want to focus on what's not working right and so forth, and we have to do that. But we have to also appreciate that for the first time, we really do have the opportunity to build out the best healthcare system in the world that could then lead to the healthiest nation, which we are not. And as the Institute of Medicine report shows last January, that when the United States is compared to 16 other comparator countries, we are last or next to last on all of 10 variables reflecting basically society's health or the public health. Life expectancy, infant mortality, obesity, you get the idea. Yet we spend twice as much per capita as the next highest spending nation in the world on healthcare. So we have a chance, we're the dog that caught the car, we actually have a chance to build out something that really makes a heck of a difference and builds the healthiest society in the world, and there's no reason that we can't do that.
But how, connect that to the law. How exactly is the law going to help us to do that?
Well, the law is the law of the land, which says basically everybody has access to health insurance, that they can get it, and indeed there's an individual mandate, they must get it. So obviously the dynamics change dramatically overnight in terms of the number of people that can get into the system. The key point that Tom points out is that obviously we focused, my organization in particular, about people not getting the care they need. I have to report to a board, as Tom does, and a decade ago I reported to them and said, you know what, we can't make our 2015 goals unless three things happen. We've got to redouble our research efforts, we've got to promote prevention into public policy, and we have to provide access to quality health care to everybody. And the last one we discovered is the only one that could keep us from ever reaching our 2015 goals. And so now we've solved that problem. Not completely solved it yet, but we have a chance to solve that problem. And I think it's an extraordinary opportunity. But we do have to worry about overtreatment. And so the key point is for people to get what they need, when they need it, where they need it, and not too little and not too much. And both of those issues have to be solved.
If I could just add to that, and what the law puts in place in addition to the coverage expansion is an emphasis on quality and an emphasis on paying for outcomes and not reimbursing for bad outcomes. And that's something that puts all of us, all the different healthcare providers, in this boat together. It means effective use of diagnostic testing, effective counseling, using preventive benefits. And that's something that, there are portions of the law that kind of kick this into motion, but that will evolve over time. And to your point, it's getting that right. It's making sure that we reimburse and reward and identify and put the right quality measures in place and figure out ways to track and use them. The combination of the HITECH Act followed by the Affordable Care Act really creates the infrastructure to do that. But it's making sure the data is used, available, and analyzed and tracked properly so that we have a continuously learning healthcare system. The healthcare system is constantly evolving. Quality measures are constantly evolving, just like medicine and diagnostics are constantly evolving. And for the first time, really, the right system is in place to do that.
There are a few things we're doing at the Free Clinic that echo general themes in the Affordable Care Act. And one is, and we've been doing this for years, is really trying to keep patients out of the hospital. And reducing unnecessary readmissions is a big theme in the ACA. So I know that when, and I actually volunteer and see patients in the Free Clinic, so when I see my patients with diabetes and we're adequately controlling their blood sugars, that we're keeping them out of emergency departments and we're reducing hospital admissions. When we also have spent a lot of time focusing on health education and prevention, another theme too, again, that we've talked about. We have a robust vaccination program, we do group health education. All these things are investments that will save money in the future and promote good health.
So we've heard a number of people talk about things like, as Kirsten said, putting providers in the boat together. We've heard not as many silos. We've heard coordination. And the word that comes to mind for me is consolidation. So we've seen consolidation in the industry in a very rapid fire kind of way since the law passed in 2010. And I'd like our panelists to talk a little bit about what have been the effects of that consolidation, where exactly we see that happening, who is consolidating, and where we are now in relation to where we were in 2010. Who exactly is consolidating? How much do we see that going on How much more of it are we going to see happen? And what are the ups and what are the downs of that consolidation?
Well, maybe I'll start. In terms of in the hospital and physician community, as I said earlier, there's been a series of different relationships that are emerging, both between hospitals as well as between hospitals and physicians. I think all of them oriented towards developing systems of care. So if we want more integrated and coordinated care in order to achieve the kind of things we're talking about, you really need the capacity. You need an organizational capacity for the capital investment that's required. Information technology alone represents for many of these organizations an expenditure of several hundred millions of dollars in order to have the information systems in order to deliver the kind of care that we're talking about, as well as the managerial capacity and the capacity to manage the risk that's associated with the new payment models that have been described here today, that all of us see as a great step forward, but you need the organizational capacity in order to do that. Hospitals themselves are both very labor intensive as well as very capital intensive. One of the concerns in many communities is unnecessary duplication and things of that nature. If we want to wring those inefficiencies out of the system, I think some degree of consolidation and partnerships need to occur. Again, how this will play out will differ locality by locality, but that I think is an important part of developing the kind of system that we're talking about in the future. That kind of consolidation, I know, has raised some concerns in some quarters about this whole question of, are the providers have more influence in the system, or do the insurance companies? If you step back and look at what we're trying to achieve in terms of a more efficient system, I do think we're coming up on a kind of a decision point on this issue, and that is that we have to decide is the creation of more organized systems of care. For example, in California, the Kaiser system is oftentimes held out as an example of what the country might want to move to. Well, the Kaiser system is an enormously integrated, consolidated system that now accounts for some 40% of all commercial insurance in California. But again, what they've been able to do with that kind of system over time is develop a lot of the efficiencies that many of us are talking about today. So I think I understand the concerns about consolidation, but I think there are regulatory solutions to that as well, so that hopefully we can get the benefit of the kind of partnerships that are being developed, but also provide the protections that people are concerned about.
I would like to echo that to an extent. The Affordable Care Act and the establishment of accountable care organizations has, I think, pushed a community that was already looking at consolidation during the managed care days one step further, but centered on for a different reason. Instead of just to cut costs, it is now to provide quality care and access across a large continuum of places where you would give care, not just a hospital, not just an academic medical center. So the thoughtful consolidation or coming together of different care sites that you're seeing in California, you're seeing in Minnesota, you see in the Shenandoah Valley in Virginia, where they're not just doing hospital to hospital, but doing hospitals and clinics and physicians' practices, and then taking a look at how are we doing things in this whole system to make sure that no matter where the patient is seen, the quality is still the same. And so in my profession, in laboratory, what we did is started to look at how a patient's specimen is handled and tested in one center as opposed to another, because there are differences in methods and instrumentation, and maybe through standardization, no matter where the patient is seen, the physician will get always the same quote-unquote result. And that will be good for patients, no matter how you look at that. If no matter where they go, that glucose or that A1C means the same, and the value is the same, you will be able to compare, and it will make us more efficient than we are today. It will also eliminate a lot of the redundancies that we currently see when a physician doesn't know whether or not the patient was seen in the clinic and reorders everything because they can't see any of it. Our hospital, our laboratory systems can bridge all the, or most of the EHRs and HIS systems that can bring that information to anybody, no matter where they are. So this is the kind of thing that I think the Act has done. The impetus is different than it was in the 90s, and I think the cooperation is going to be different.
Yeah, and I'd like to just sort of jump in, and Tom had mentioned, some of the changes in financial models, and and one of them being the notion of bundled payment, which bundled payment won't fit for every problem, healthcare problem, but by having bundled payment, everybody has a stake in the game, in terms of primary care, rehab, acute care. I mean, and that is. That may prove to be a powerful consolidator of people with shared interests and wanting to do well, coupled with sort of the outcome measures, that will be attendant to that. So,
okay, why don't we open up to questions from the audience? I believe we have some folks walking around with microphones. I see a hand up in the middle here. If you could please identify yourself. And if you have a particular panelist you're addressing your question to, just let us know.
I'm Dr. Caroline Poplin. I'm a primary care physician. I volunteer at the Arlington Free Clinic. My question is for the gentleman from Cedars-Sinai. We heard earlier this morning that Cedars-Sinai is not going to be part of the network for any of the care plans that are going to be offered on the California Exchange.
Right.
I was wondering how that is for you, and if you're planning to make any changes.
Sure. Yeah, I appreciated the shout out earlier in the program. I think the question's a good one because, again, a couple of things. One, it illustrates the point I was making earlier that how the law is being rolled out is going to be very different state by state, and so and we need to recognize those kind of dynamics. Two, with regard to the California situation, your observation is correct. It's not just Cedars-Sinai. The networks that have been put together for the California Exchange are more limited than the traditional commercial insurance market. And I think we should recognize we're embarked on a grand